for our speaker today. And it's really my pleasure to introduce the first three speakers, and Dr. Kilmax will introduce the others. So first we have Dr. Rhoda Ate. He's a medical doctor working at NCD within the International Health Regulation Division of the Surveillance Department of NCDC, currently pillar lead for surveillance within the COVID Emergency Operations Center in Nigeria. And then our second speaker is Dr. Sabine Nzanzimana, who's the Director General of Rwanda Biomedical Center of Ministry of Health in Kigali. And then our third speaker is Dr. Hassan Mohamed, who is a public health medicine specialist within the Department of Health in Cape Town, South Africa. So let me pass to Dr. Kilmax to introduce himself and others. Peter.
Thank you, John. Hello, everybody. I'm Dr. Peter Kilmarx. I'm the Deputy Director of the Fogarty International Center at the U.S. National Institutes of Health. I want to also welcome you to today's webinar, which we're delighted to co-host with AFREhealth. So one of the reasons given for relatively low rates of COVID-19 in Africa is the robust public health response, including contact tracing. Meanwhile, contact tracing has not been successfully implemented in most jurisdictions of the United States and in many other Western countries. So the goal of today's webinar is to share best practices from Africa for both South-South and South-North information exchange. Thanks to Jean for introducing our first three speakers. It's my pleasure to also introduce Dr. Alex Rio-Alexis Ario. He's the director of the Uganda National Institute of Public Health and program director of the Uganda Public Health Fellowship Program. He has extensive knowledge in disease prevention and control, health policy management and planning, health systems reform, and quality improvement models. Lastly, Dr. Jay Varma is a senior advisor for public health. He's playing a lead role in the COVID-19 response in the New York City's mayor's office. And previously, he was a senior advisor to the director of the Africa CDC. And he's also led public health research and programs in Asia and the US with the US CDC. So we've asked each speaker to talk about COVID-19 in their country with details on contact tracing, implementation, and outcomes, and key best practices they can share. Each country speaker will have 10 minutes, followed by 5 minutes of discussion. Dr. Varma will then discuss considerations for implementation in Africa and relevance to the US and other high-income countries. If we can keep on time, we'll have 10 minutes of discussion at the end. So please mute your microphones unless you're speaking, and please do use the chat room for questions, comments, and sharing links to resources. And so now over to Dr. Rhoda Ate from Nigeria. Rhoda, can you share your screen?
Thank you. Good afternoon, everyone. Yes, can you hear me?
We can hear you.
Good afternoon, can you hear me?
We can hear you. Yep.
Okay.
Share your screen.
Thank you very much. My name is Rhoda. So I'll be for Nigeria. Can you see my screen? No, not yet.
No, we can't. Why don't we all turn off our video to cut down on the bandwidth?
It seems I'm no longer a host, so I can't share my screen. Can you make me a co-host so that I can do that?
Yeah, sorry, you left us and came back. Now you're a co-host again.
Okay. Okay, thank you. So Nigeria particularly, throughout the COVID-19 response, contact tracing has been one of the key strategies we have used in our response from the beginning, and we still continue to do so. From the time when the strategies were around how to mitigate the spread of the outbreak, and even now, we're in places where we still have widespread community transmission, we are still using contact tracing as one of the strategies in our response. So, looking at the trend in our cases over the last 40 weeks, if you look at that graph, you would see that when the outbreak started, we had a steady increase in the number of cases, and our trends were upwards in cases, and our testing continued to also go up, though relatively compared with the population that we have, our testing is relatively low compared to our population size, but we did rapidly expand the capacity to test by setting up laboratories. Now we have over 60, and we had just one laboratory at the beginning of the outbreak. So, and then a decline in cases, which was a decline in the number of tests that were able to perform.
Rhoda, your audio quality is really not good.
Of increasing risk perception was becoming increasingly low across the country. So a lot of people, because of the case fatality, which was very low for COVID, so within communities, a lot of people were no longer as eager to actually come out testing as they did at the beginning of the outbreak. Can you hear me?
It's better.
Hello?
It's
Can
better
everyone
now.
hear me?
It's better now. Go ahead.
Can everyone hear me?
Yes, we can hear you now.
Can everyone hear me?
Yes,
Hello?
we can hear you now. Go ahead, Rhoda.
Hello, can you hear me?
Yes, we can hear you. Go ahead, Rhoda.
Hello, can everyone hear me? I couldn't hear you at some point.
Yeah.
Oh, okay, okay. So we have continued to have a decline in cases and in testing among communities. And we have tried to put in place, of course, strategies to improve cases, to more active strategies to identify more cases. However, just to say that it's test positivity rates have continued to go down. So it's an assessment that actually transmission rates are also reducing within the communities. So, this daily Epi curve actually shows cases and deaths, and you notice that case fatalities are relatively low at 2.2%. And a lot of our cases have reported some kind of history of contact with either a probable or a confirmed case of COVID. So currently, 1,000 cases, we have 59,000 actually, sorry about that, have actually a history of contact, or can show that they have actually been in contact with a positive or a probable case. So the response, of course, when the response started, one of the first things we did in the country was to start monitoring of cases at the points of entry, international airports, land borders, to monitor people coming in, checking for or doing temperature monitoring and taking histories and then tracking those cases to see if they would have symptoms over 14 days. Eventually, we moved to full restrictions on all international travels. And currently now we have started easing up on those restrictions, and we have actually lifted a lot of restrictions that we put initially. And then we also moved to various degrees of movement restrictions within the country, lockdowns in states that had a higher burden. Eventually we had a national zone movement. A lot of those also been lifted. And then now currently a lot of pharmaceutical interventions like physical distancing,
Rhoda, are you still with us?
Rhoda, can you hear us? I think we lost her.
Is she still connected? I think she's disconnected. Why don't we go ahead? I don't think Sabine is joined, so why don't we go ahead to Hassan and Masuda from South Africa?
Yeah, we can present. So Masuda, if you can share your presentation, and then we can kick off things.
Can you see the slide?
Yes, I can see the slide, so that's working well. You can hear me clearly, Masuda?
Yes, loud and clear.
Yes, yes, Hassan.
Great. So I think just briefly, Masuda and I work in the Western Cape province of South Africa, and that's where our focus has been, and we'll talk about our experience there. I'm a specialist and she's a specialist in training, and we are both actively involved in coordinating contact tracing. Next slide. This is an overview of our epidemic. So nationally, we've had more than 600,000 cases, close to 700,000. And at one stage, we were fifth in numbers of cases in the world. So not a very good space to be. In the Western Cape so far, we've had 109,000 cases. And initially, we were the epicenter of the epidemic. If you look on the right-hand side of the slide, you'll see our number of cases. We've had a peak in June, and we're in a phase now where we've come off the peak, and we have a fairly slow, steady stream of cases. The graph below that shows the distribution by age of cases, and then of course the distribution of age of deaths, showing deaths occurring much more commonly in older age groups. Next slide. These are the key milestones in South Africa. So you know all know when Wuhan was had the first cases, and when WHO declared COVID-19 public health emergency. So in South Africa, our first case was on the 5th of March, and the president very quickly announced a national state of disaster and instituted lockdown measures quite quickly, and we had quite a substantial lockdown introduced by March the 27th. So this is a key part of our response, was a very rapid transition to lockdown procedures. Since then, we've gradually lifted in levels more the lockdown restrictions, and we're now at the lowest level, which is level 1. Population level mask wearing and distancing was introduced in the course of April, and community screening and testing was introduced in the course of April as well. Next slide. So for contact tracing details, I'm going to hand over to Masuda to talk to this. Go ahead, Masuda.
Thanks, Hassan. So I'll be talking a bit more about the contact tracing process and the challenges that we faced in the Western Cape, especially from the outbreak response team. So just to describe the geography of the Western Cape, specifically of South Africa, it's one of the 9 provinces in South Africa. And the Western Cape is divided into 2 main regions. So there's the larger rural region and the smaller in size Cape Metro area. And each region has its own district, and then each district is then further subdivided into sub-districts. So the rural region has a larger surface area, but the city of Cape Town, which forms the Cape Metro area, is a lot more densely populated than the rural districts of the Western Cape. So these divisions allowed for very natural division in the outbreak response from the Department of Health's perspective, because there were pre-existing teams and these pre-existing divisions within the Department of Health between rural and metro that allowed for commencement of outbreak response by region. And so, for example, if there was a new positive case in a rural district or sub-district, it would be followed up by the rural team, and vice versa for the Cape Metro area. So this brings us to the different resources involved in the outbreak response in the Western Cape. So firstly, we had the Central Provincial Outbreak Response Team, which was made up of public health medicine specialists and registrars, and other members, epidemiologists, who all form part of the Health Impact Assessment Unit at the Department of Health in the Western Cape. And at the central level, we coordinated the outbreak response in the province. The central team was supported by the designated metro and rural field teams, and they would further conduct the case and contact tracing in the different regions. And they were further supported by pods, which were mainly made up of volunteers, of doctors, medical students, allied health workers, and also non-health workers. And they would actually conduct the case and contact tracing for the various field teams, which were designated by the sub-district. And then lastly, but not least, we have the Provincial Health Data Center, which is a unit in the Department of Health, which is comprised of public health medicine specialists and registrars, epidemiologists, and then also data specialists and developers. And they were central in the development of the main electronic database called Single Patient Viewer, or SPV. So this application, it's an application that's used by management and by clinicians before COVID for collating information of public sector patients into a single application. And for the purpose of the outbreak response, it was repurposed to use for case and contact tracing. So what it was able to do was, because it had these links, the data center also generated new links to collate all the information, all the positive cases from the laboratories, both public and private, as well as the electronic hospital admission systems, into a single line listing, and provided details of all COVID-19 cases in a single line listing that could be accessed by the different contact tracing teams. So this goes into the actual process that was involved, that took place when conducting contact tracing in the province. Just to note that initially, in the very beginning of the outbreak, this process was controlled at the central level, but we soon realized that it was becoming too overwhelming to control at the central level, and so we started a decentralized process from quite early on, to allow the field teams to control or take charge of the outbreak response in the different sub-districts. So basically what happens is that SPV pulls all of the cases into the single line listing, and the sub-district field teams are able to access this line listing on a daily basis and allocate cases to their various pods, the contact tracing pods, to conduct the contact tracing. These volunteer pods conduct the contact tracing. They inform cases about sometimes they inform cases about their positive status, and they conduct counseling and provide further information to them. And then more importantly, they inform them that they need to isolate themselves if they are not hospitalized. Where isolation or quarantine isn't feasible, as you know, or you may know, that many homes in the Western Cape and the rest of South Africa, there are sometimes whole families, multiple people living in a single unit or a single room, which makes quarantining or isolation it makes it impossible to do. And if this was the case, the case or contact tracer would find out about their home circumstances and offer them a separate quarantine or isolation facility, which they are then offered transport to be moved to. Contacts are also informed either in the same manner or via the case themselves. And then these cases and their contacts are monitored by the field teams for the full 10-day isolation or quarantine period. Where necessary, home visits are also done by the field teams. And this is especially if cases or contacts are not contactable, which happen quite often, or if their home circumstances need to be assessed, if they have issues such as food insecurity, if they're unable to get food to their home, or don't have anyone to deliver food to them if they need to be in isolation. Also, workplaces are engaged with to ensure that the workplace monitors and conducts their work contact tracing within the workplace themselves as per legislation. And airline contacts were also followed up by obtaining airline manifests from the airline companies, which were sometimes delayed, but sometimes worked quite well, quite smoothly. And then lastly, we were quite fortunate that legislation also allowed for action to be taken against anyone unwilling to isolate, or if quarantine wasn't appropriately adhered to by those who were meant to be in quarantine or isolation. Hassan?
Okay, so in terms of use of electronic applications, our National Department of Health developed two applications. The one was called COVID Connect, which was essentially a WhatsApp notification tool. So anyone who was diagnosed and had a positive laboratory result was notified, and that person, using their date of birth, could obtain their results. They could also, through this application, notify the Department of Health who their contacts were, and they could also electronically notify daily monitoring of symptoms via this application. The second was an application called COVID Alert, which has been promoted widely throughout South Africa. It's a Bluetooth type application, so that if you came into contact with someone who was a case, you would then be informed that you were in contact with a case. I think it's important to note that both of these applications had fairly limited uptake by the population, although they were quite actively promoted. Next slide. Just in terms of our metrics, so the yellow line that you see, is proportion of cases we were able to contact, which was roughly between 70 and 80%. This is just recent data over the August-September period, and this speaks to the challenge we had in being able to contact people because of the lack of accurate telephone details. We were much more successful in getting hold of contacts and notifying them to quarantine. Next slide. So just some of the challenges, as I've mentioned, difficult to get hold of cases in terms of contact details. Probably the first point that I've made, which I'll come to, is that, you know, although we had comprehensive testing strategies, we did not detect all the cases. And I'll discuss that in a little bit more detail on the next slide. Ability to quarantine or isolate in poor socioeconomic conditions in dense townships or informal areas was a big challenge. But at the same time, although we had off-site isolation facilities, community members were not always willing to go to such facilities, partly because of stigma, partly because of fear of loss of their possessions or what would happen to their own homes should they go to an isolation facilities. But although we promoted these facilities, there was a reluctance to utilize them, particularly by people living in poor communities. Of course, adherence by cases and contacts to isolation and quarantine requirements was a challenge. We did not monitor that. We did not know for sure whether they adhered to these requirements, and often had anecdotal reports that people didn't adhere to the isolation and quarantine requirements. And then, of course, establishing effective reporting mechanisms has been a bit difficult. Next slide.
Just a minute left.
So in terms of challenges, I think an important point to mention here is we knew about certain number of cases. We knew some of those that were high risk, but in terms of the actual number of cases, we missed out on a large number, and our serological surveys have illustrated that. Next slide. In terms of best practices, we feel that health service and community preparation and planning is important. The electronic database that we had of getting both public and private sector results was crucial to our response. Decentralization of follow-up was very important for us. And of course, we think that promotion of population-based infection control practices was very important in limiting spread. Next slide. So in conclusion, we had a substantial epidemic. Both our lockdown measures and contact tracing are believed to have at least had some effect in limiting the extent of the epidemic, but we did experience many challenges. We're focusing on the recovery of services, but we're putting in place surveillance mechanisms to be alert to a possible second wave. And our current strategy is that we need to be agile and scalable in order to respond quickly should we experience a second wave. Thanks very much. That ends our presentation.
Thank you, Hassan. I think we're going to Peter. Is Sabine, any sign of Sabine?
Well, let's go ahead.
Yes, I'm here. Hello.
Hi, Sabine. We're going to go ahead with Dr. Ario in Uganda next and give Sabine a chance to get settled.
Okay.
Alex, can you share your screen?
Yeah, let me do so. Okay. Good afternoon, good morning, everyone. I think I was already introduced by Peter, so I won't repeat it, but I'll take you through contact tracing during this outbreak of COVID in Uganda. As you may be aware, Uganda declared the first case of COVID on the 21st of March, 2020. And this data I'm giving you is as per 28th of September. We've had 2 waves so far. The first wave actually we had was on 30th of May. That's when we had the first peak. And now we have the second wave. Now, by the 28th of September, where I'm presenting the data, we had already reached 8,000 Ugandans and affecting 3/4 of the districts in the country, with a case fatality rate of 1%. Now, the initial phase, of course, we had more or less like the curve was going down, but then it jumped up. Now, officially now, when you look at this epi curve, the brown one is actually community transmissions. And then the other color, which is like slightly blue, in the imported cases. So you realize that actually officially now we are in phase 4 of the epidemic because we have sustained community transmission. Now, at the initial phase, of course, we developed a national COVID response plan where we activated the incident management system, which coordinated the public health mitigation measures at all levels. And we actually managed to contain the epidemic at that point in time. Now, a number of things, of course, were done, including a lockdown. But then when the lockdown was lifted, we started realizing the lockdown actually was lifted on the 4th of June. Now, that is when many of the measures started going down and not the way it was before from the beginning. Now, we started realizing a surge in cases. Now, the initial phase, of course, in our response plan had combined strategies. So we had the strategies of testing, contact tracing, alert management, case management, and risk communication. Now, that helped us a lot. And of course, we tested quite a number of people. That by 28th of September, we already tested 478,000, and that gives us a positivity rate of about 1.7%. Now, so in terms of this one, actually, I've talked about the mitigation measures. Now, in terms of contact tracing as a strategy, it's a surveillance strategy, of course, which is meant to rapidly detect and isolate cases in Uganda. Now, following confirmation, of course, of a case. Now, we all know who a contact is. Now, in our case, we, of course, identify and list these contacts, and then we test them and monitor them for symptoms. So we test them on day 0. That is when we just identified them. And then on day 7 and day 13. Now, so then we follow them up for 14 days. And during this period, they would be in self-quarantine. Now, once they test positive, of course, they become cases, and then we transfer them to isolation. Now, of course, the goal of keeping them in self-quarantine is basically really to interrupt transmission. Now, so we have actually managed to do that using a system where it's basically a central system. Our contact tracing team is a central team that actually goes to the regions. We have 14 Ministry of Health regions. So we have regional contact tracing teams that actually identify these contacts and follow them up. Now, the regional contact teams, of course, maintains communication with the laboratory and surveillance teams, and then the case management teams. At the same time, they actually link very well with the central team, which manages data at the central level. And then, of course, reports to the National Incident Management Team on a daily basis. Now, the system that we use is actually the GO data. The GO data is, of course, is a WHO tool, which is meant to collect data during public health emergencies. And we've used it quite well during this period, contact tracing. So each of those contacts that we get, we enter the data into the system. And even when they are tested on day 0, 7, and then 13 during the 14-day follow-up, we actually do that. So this is a software which is actually very useful, and for contact tracing, we found it actually fairly useful. Much as initially we had a problem of the load, but we actually managed to use it quite well. Now, by 28th September, we had actually managed to list 41,000 contacts. And out of those, we managed to to follow up 33,000 who had completed their 14 days follow-up. Now, out of these contacts, we've had 8.6% that have turned out positive. And of course, that means our secondary attack rate in Uganda is actually 8.6%. Now, in terms of the contribution to the total number of the total case count, our contacts contribute 45% of the contacts. So that makes it the highest, actually followed by alerts. So our contacts are actually turning out to contribute to cases much more than other alerts or imported cases. Now, recently, of course, in the month of August and September, we noticed a rapid increase in cases and contacts. And initially, when you look at our Epi curve shows you quite well, you realize that initially we had a lengthy doubling time. But in the month of August, we started seeing a decrease in doubling time. And in September, we started seeing actually our doubling time coming to about 4 days or so. And of course, this is an indication of the increased magnitude of infections. So this expanding number of cases and contacts, of course, exceeds the capacity of the central level team to actually support all the regions and the districts. And contact tracing becomes really resource demanding. So using a central team to do the contact tracing becomes more or less impossible because you have to deploy the teams, you have to transport them, you have to meet the reporting needs. So it becomes extremely costly with this kind of, in fact, it reaches a point now where even just doing the contact tracing alone, you really have to think about whether you really have to follow all the contacts, because with the large numbers that we are having of community transmissions, it becomes more or less impossible to do contact tracing. So if you're using a central team, it becomes even more challenging. So to address this challenge of maintaining this central mechanism, we realized that it won't work. So we took a decision as a country to actually decentralize our contact tracing using our established community systems. But that, of course, also requires capacity building and making sure that they know what to do, they know what kind of data they have to submit. Short of that, you won't even get the kind of data that you would want. Now, but of course, we managed to do that with a lot of challenges, and we are now beginning to use that community system to make sure that we actually cut transmission. Now, what lessons have we learned? Now, what we have learned is that contact tracing plays a fundamental role in early case detection and interruption. So if you combine it with, of course, the non-pharmaceutical interventions at the beginning, you actually cut transmission. And then with the lockdown, so it worked very well at the beginning, but it requires a dedicated team. But also we, of course, learned one very fundamental lesson is that a central team, which is very highly resource demanding, is not the best way in a huge outbreak like this COVID-19. So you need a decentralized system where we use the community structures. So transitioning to, of course, the district mechanisms and then using the community health teams, we found it a little bit more feasible, and that should actually be a lesson that many countries should learn. So in summary, this is what we've managed to do in contact tracing in Uganda, and we learned the very, very good lessons in the beginning, that it actually cuts transmission. But you do not need to maintain a central team. Otherwise, you cannot do it in a large outbreak like this COVID-19. Thank you very much for listening to me.
Thank you, Alex. Terrific presentation. Okay, we have a couple minutes for questions. We're a bit behind overall, but you've kept the time, so we wanted to ask you a couple of questions. Please put any questions in the chat. Let me just start out by asking Alex, are you still using the same software communication system? Has that been now rolled out to the district and community level? And then what kind of results are you seeing currently with your new district-led format in terms of the contact tracing success?
Yeah, thank you very much, Peter, for that question. Actually, when we started using decentralized system, where we are using now the districts actually to report using this, the ODK, we of course noticed a challenge. Reporting was not, was actually below 70%, but we identified the challenge. We found the challenges was actually network, the challenges was workload, and a number of other challenges. So when we addressed the challenges, we started noticing actually the reporting rate increasing to a level now which is actually very acceptable. So we have actually managed to address that, and we are now getting actually more complete data from the districts.
And in terms of the proportion of contacts being traced, how is that going? Is that recovered?
Yes, but of course, as I've told you, where we've reached now is more or less impossible to actually trace all contacts, basically because of the volume of the contacts. Because we are having situations where you're having all this sustained transmission. So the districts are still trying their best to actually trace contacts as much as possible, but we are not aiming now at actually tracing everybody because it becomes literally impossible to do that.
I see. So even with the decentralization, it's still an overwhelming number.
Absolutely, it's an overwhelming number.
I see. Okay.
Yeah.
Well, why don't we go on? Well, there is another question from Cecile in the chat. What percent of the, what percent of the, what's the percentage of symptomatic versus asymptomatic among the contacts who turned out to be cases? So,
now,
go ahead.
The percentage of the contacts that, let me see, percentage of symptomatic stroke among the contacts of the 8.6% who turned out positive. Okay, of this 8.6%, how many turned? Now, in our all data, which is actually not very different from, of course, those who are pre-symptomatic and then they become symptomatic. What we have actually realized is that from our data, we are now seeing more symptomatic patients than asymptomatic. Initially, we actually were seeing, our percentage was 67% asymptomatic, and then only 37%. But now we are seeing that reduction. So we are seeing more symptomatic patients than asymptomatic, both in contacts who are actually turning, who are developing symptoms, and for even the other ones, like for the alert cases.
Okay, then the last question before we move on is about the success in the testing. You said you're testing at day 0, 7, and I think 13 of the contacts. What's the success there, and how are the samples being collected?
No, actually, the way we collect the samples, we of course collect samples from all the contacts. That's one. We also collect samples from all the alerts. So we receive alerts and we follow up on all these alerts. So every alert that we get or every contact that we manage to list, we actually test them. So they do not have to go to the health facilities. Of course, we have those that like go to quarantine centers and then we test them and whatever, but we test all the alerts that come into our system and we test all the contacts.
And is that, are they tested at home? Is the specimen collection at home, or do they come to the health facility?
Now, there are those who actually come to the health facility, but then there are those, actually one thing also which I need to mention is that we have actually done 2 rapid surveys. We've done 2 rapid assessments to determine community transmission. So those ones we actually collected specimens from the community. And then for the contacts, we actually follow them up. If they are in self-quarantine, we actually follow them up and we take samples from where they are, from where they are quarantined. So they do not necessarily have to come to the facility for testing. We actually go follow them up and we take the samples.
Thank you. We have some great questions, but we need to move on. Maybe we can save some questions for the end. Let's go on to Dr. Sabine Sanzimana, who's the director of the Rwanda Biomedical Center. Sabine, over to you, please.
Great. Good afternoon, good morning. So it's a pleasure to join in this discussion. I'll have a few slides to go through about contact tracing and COVID. response in Rwanda. So probably use a few minutes as we try to catch up with time. I don't know if you can put up on the slides. So we shared earlier, or if you want me to. All right. Thank you so much. So the response to COVID-19 in Rwanda, like in many other countries in the world, has been like a lesson to all of us working in the health sector. But the quick organization that we put in place in Rwanda on the next slide is actually to make sure that different sectors, different ministries are working together in this structure that we coordinated at the National Epidemic Preparedness and Response Committee, chaired by the Right Honorable Prime Minister, and it's involved different sectors, different ministries. So this committee also has we have established a command post, a national command post, that involves people from different sectors, partners at the national level, also provincial and district levels. So you would see that we had organized into epidemiology response, surveillance, case management, laboratory, data science, administration and logistics, of course, for a lot of logistics and materials that are needed in this type of operations. And of course, communication and public health measures, follow-up and implementation by security, local government, and also health personnel. So I wouldn't forget to mention that we have also an expert scientific advisory group that involves different scientists in Rwanda and outside of Rwanda. And of course, we have a framework of partners coordination. So I would say that this is the driving force of the response from the beginning until today. And we've been working mainly using the data as they come up. So the first thing I'll probably go quickly is on public health measures that were put in place even early days before COVID. First cases were reported in Rwanda, like hand washing in different bus stops, in public gatherings. Universal face mask was also enforced. Physical distancing, as you can see on these pictures, in the most popular Kigali's bus stop, and also testing, and of course using technology and the IT solutions. On the next slide, maybe you can move faster. I want to take you through the key epidemiological data that we've been monitoring at different times. So today we've cumulatively 4,866 cases of COVID-19 that ever confirmed, of which 3,216 recovered, with a recovery rate about 66%, and case fatality ratio about 5 per 1,000 cases. So you would see that on this graph, how at the beginning you have a high increase of cases, while recoveries also took over in green, and in red, these are cases still in treatment centers, and fewer cases that actually passed away. I will show you in the next slides who are these people and their gender and other factors. So next is who are these people? The first on the left up is actually the age distribution among our cases. You'll see that those who are aged 20 to 39, the majority represent actually more than 89% of our cases, while those who are much older are fewer in general. With males representing 64% of our cases. On the bottom of these slides on the left is actually the summary of distribution among deaths we've had since the beginning of this pandemic. And you'll see that these two slides, left up and left down, are going in the opposite directions. We're actually having more people dying in the older age categories than younger age, while the sex distribution among female and males is not so much different as for cases on above par right side of these slides. Quickly on the laboratory diagnostic, as I said, we've been conducting a number of tests every day with an average of about 4,000 tests conducted every day. So far, we've done more than 500,000 tests, PCR tests in Rwanda, with an overall percentage positivity rate of 1%. But the last 7 days has been 0.3%. We are using different laboratory platforms, including like Abbott M2000, Roche Cobas. We're using also other types of PCR platforms. And recently we introduced rapid antigen tests, the same that actually been approved for emergency use. So moving on the next part of this presentation, we've been also monitoring the reproduction number of cases over time. We've had time where cases really increased up, like in mid-September, and then it went down to less than 1. As of today, the cases seems to be fewer than early before. And we monitor these indicators every day to see how we can take more public health measures. But I'll probably focus on my next few slides on contact tracing and how we've done it as purpose of this discussion. Since the beginning, from the first case on March 14th, we've been monitoring both prospectively and retrospectively each case that were identified as an index. So we've set up a team of contact tracers, as you can see on this picture on the left. And early on, when His Excellency the President of Rwanda came to visit our response, our command center, you see the groups that each team had a case to follow. So we started with one team that every time we had a case, we increased the teams. We ended up by having different cases per team that we're following each case and making sure that the contacts are also found and tested, as we had set up testing sites in Kigali, particularly at different stadiums, different public places where we could establish sample collection centers. And I said multi-sectoral collaboration and different partners were involved in this process, and the use of technology made it much easier. Moving on to the key highlights in terms of numbers. Of the 4,866 cases we've ever had, we've identified 19,000 contacts that are traced and checked. Some are accessible. Of course, this brings the challenge of some contacts that are either not accessible at all. They're not many, but still they are there. And also there are those you trace and we find they're not in country. This brings the element of this global partnership. You would see cases that came by air and returned, or maybe it's a neighboring country that has moved far. So this brings the complexity of contact tracing in this global context. So we have a positivity rate of about 2% in terms of in those cases that we've been testing over time, with a ratio case to close contacts, one case having about 4 contacts. So this highlight can be accessed actually live on our website under biomedical centers. So we made it public so that people can also see what we do in real time on a daily basis. So every time we had a case on this diagram, we made sure that is early detection and testing, as well as quarantine of contacts. And of course, contact tracing would follow every single case. But as my colleague from Uganda mentioned, as cases become more and more, it becomes also complex to contact every single case. And that's where technology comes in. That's where decentralization comes in. And now we actually doing home-based care of mild cases, while those cases that need special attention, critical care, ICUs, oxygen, ventilation, managed in the treatment centers. But this doesn't stop the contact tracing mainly that are happening using technology for home-based and also having command posts at decentralized levels. So moving on to the next slide, we just put together complexity of IT solutions that we are using. I'll quickly go through this to make it short. On the left up left is the geospatial using mapping, and every case we evacuate or we trace, we have a system that we indicate where this case has been located, being in a household or in a treatment center. And every time we map these contacts, so it's easier to trace them and to communicate with them using our contact tracers. In the middle, this is a system that we've used in the HIV program before for Walter system that sends SMS exchange and also can video calls with contacts, can accommodate so many contacts and with few people monitoring it. And on the right side up is actually another tool, Blastlet, that we are using for home-based monitoring, that is fencing, ensuring that people who are told, who are isolated, consent to stay home, do not move, actually from home, going to markets or wherever. So we have these devices that are also very useful instead of having people in isolation centers. This is easier. It cuts costs, but also keeps people safe at home. On the bottom left is also another way we've used in our region for tracking truck drivers using GPS in their vehicles so that we can know where they stopped. Once we found they are positive, those red dots are different stop points. And these lines in green, yellow, these are ranges in kilometers. So we've been testing these areas according to the ranges where truck drivers who identified positive could have stopped on the roads across Rwanda. As you know, we've 4 countries at our borders where movements of goods continued, even during lockdown. So we have also other mathematical algorithms that we're using for contact tracing, particularly for this mobility. And we have this dashboard on the right bottom side that shows us the real-time different data. As I said, these are available on our public dashboard. Moving on to the next slides, I probably have a few to mention the challenges and lessons learned. So we've seen that having infrastructure, having technology, having programs like these systems used in the HIV program or in laboratory systems, adapting to COVID response has been one of the key, I would say, enabler or opportunity that we had in infectious disease response. And of course, using data and technology quickly in a pandemic helps to gain to be ahead of the virus in some ways, and also decentralization and ensuring that there is a comprehensive response from all sectors. And some challenges, the next slide, probably my last before I hand over to other speakers, is on the next one is what are we doing now to make sure if you do contact tracing, you need to know who has the virus, who has infected who, and so that you can take measures or even know who else should we find before it reaches the vulnerable and those who are at risk to die from this virus. So we've been working in the National Reference Laboratory to put in place genomic sequencing as an additional tool to make sure the contact tracing, the infections, we know the super spreaders, or retrospective review of where this mass transmission are happening as we reopen the economy. The other aim for this epidemiological tracing is not only to call and find, is to to understand which virus is circulating from who to who. And this is one of our major priority and major challenge as we make sure we have this capacity of sequencing and also complementary to our lab and tracing teams. So I'd like to pause here and thank you for giving me this opportunity to discuss our experience. Thank you. Over to you.
Okay. Thank you very much, Sabine. Very interesting and thanks for sharing those innovations. Just a quick question coming from some of the members of the audience about how stigma impact the contact tracing activity. And obviously in Rwanda, given the low number and the low positivity rate, contact tracing is somewhat a bit easier, but do you think some behavior reaction like stigma or other is being at play, or there been some education and training on that level?
So that's an interesting question. In terms of stigma and actually challenges of announcing of result or accepting of this, in the beginning, it was an issue for many programs because no one wants to hear this terrible announcement that you've had a virus and therefore it's going to be a problem for you. But as people get to understand how COVID is managed, is treated, as we get more and more cases, this has no longer been an issue for us. Today, of course, we had to balance and ensure that people don't think that if COVID doesn't take lives of hundreds of people, it can still take lives of people who are vulnerable. And therefore, having a COVID in this time is a challenge. Someone can have it and transmit it to those ones who are vulnerable. So it shifted from terrible disease and therefore stigma and discrimination in communities in early March this year. And now we are dealing with the aspect of ensuring that if people are actually having COVID and think that is okay and you can disclose it, it should not be an issue to not protect those who are vulnerable, because we've been seeing this kind of feedback from communities.
Yeah. Thank you very much. Peter, back to you.
Sabine, and fantastic work and presentation. We're going to try back to Rhoda in Nigeria again. Rhoda, can you share your screen?
Okay, thank you. Can you enable me to do that? Okay, I'm very sorry about the break. I'm currently out on the field, actually somewhere in one of the states, so my internet is actually really in and out. So I'll focus just on the contact tracing aspect of it. So I had earlier said that contact tracing was something we started since we recorded the first case, and we've continued to use it even where we have actually identified that community transmission is widespread, because apart from helping us to limit the number of cases, it allows us to quickly identify suspected cases and quickly test them. And it's also contributing really to our case finding efforts. So the contact tracing process, when we first started and the number of cases we started, we were few. In a lot of states in the country, contact tracing was teams were really centralized within the states. As the number of cases grew, of course, this could not be sustained, and eventually now we are decentralizing our contact tracing activities and to district levels so that we can have the critical mass of human resource that we need to actually adequately do contact tracing. Most of the contact tracers are people who are actually from the community. Many of them are persons who have been trained in other programs to do community level activities. Like we are using a lot of people who were working on the polio program, who were already embedded within these communities and had good relationship and linkages with the community members to actually drive the contact tracing process. And at every district level, of course, there's a supervision that is provided by the surveillance officer who is in charge of every district. And we also have clear guidelines and processes that guide the contact tracing process. And we, as part of the process, we actually do identification immediately. A suspected case or a confirmed case is seen. And after that case is confirmed, definitely we begin the process of the contact tracing. And we try to categorize our contracts into those whose exposure risk was very low and those who had a high exposure risk, so that we actually manage them differently. For those with a low exposure risk, we focus on doing self-isolation at home and also monitoring them remotely, mostly for the period of the 14 days. But for those who were really close contacts, we focus on ensuring that the self-isolation facilities are adequate. Where they are not adequate, we try to have them do an institutional kind of quarantine. And we do, in addition to actually doing a remote follow-up, we do encourage 3 physical visits at least within the monitoring period. So some of the contact tracing structure, the contact tracing structure that we have right now is leveraging on. Hello, can you hear me?
Yes.
Hello? Okay, just checking. So the contact tracing structure right now we leverage on the experiences that we learned from the contact tracing we currently do with Lassa fever. Contact tracing is a big part of the Lassa fever response. And contact tracing was also critical to the response to Ebola in the country. So we actually adopted a lot of the processes and structures that we had for that. And currently, contact identification is done by interviewing the cases. We are currently not using any kind of IT or proximity apps to identify who was in the proximity of the case. So we do it by interviewing and finding out what has happened within the period the person was infectious. So we try to use some indicators to actually see how well we are doing with contact tracing. The 2 major things we do is we try to do a ratio of a contact. Now, how many contacts we identified to every case that was identified in each state. And we do that to get a sense of whether enough contacts are being identified for the cases. And what we have discovered with this is that ratio is very low. We set a target of about at least 5 contacts to every case. And while trying to identify where the problem is, we discovered that most of the challenge was that in many cases, cases are identified, but at the point at which results are received from these cases, some of the cases are lost to follow up or become resistant and do not want to cooperate with the state teams. And because of that, a lot of cases identified, not a single contact is actually traced for those particular cases that could not be followed up. But for those that are identified, we also check how many we have been able to follow up. And I think we're doing relatively okay in this. I think we have, as of today, we had identified about 87,000 contacts across the 37 states in Nigeria. And we are tracing or have successfully finished tracing about 81,000 of those contacts. So about the contribution also of contact tracing to case finding. So one of the things we have been doing to improve case finding is to identify some priority categories of persons to be tested. So part of what we have put in our strategies right now is to test every contact that is identified to see whether they are positive or not. That is supposed to help to boost our case finding. And we have also, so about 7% so far of the contacts that have been successfully traced have been tested and have become cases. And then among our positive cases as a whole, about 26% of them have a positive history of contact with one person who was either a confirmed or a probable case. So, so like I said, the privatization of the need for contact tracing, really the challenge we're having is that as the cases increase, the human resource capacity that is needed to do contact tracing and the logistics for the movement of these contact tracers has become a challenge, especially in states that have the higher burden of cases. So what we are doing decentralization of contact tracing. We have started the process of training more contact, identifying in all districts in the country and training these contact tracers and putting them in the communities there to do the contact tracing work. So that's something that is going on, and we have also a lot of our partners are now coming up to support us in that process, and then putting in more contact tracers in different communities so that they can support that process. So some of the major challenges we have encountered with contact tracing has stemmed from communities that we are actually tracing. One of the major things is that there's a lot of misinformation, stigma around COVID, and a lot of resistance to contact tracing. In fact, we have had, in some cases, reports of teams being actually attacked in the field while they are trying to do contact tracing because of how resistant people have become to any activities that have to do with COVID. So one of the lessons we have learned from this is that for us to be successful at this, we need to do even more community engagement. We need to continue to do the community engagement before the process, as we go through the process of contact tracing, so that the key people, the key influencers, the decision makers within communities can actually support us to inform and get their communities to be more open to all these activities happening. So some of the other challenges is that, you know, we are not currently using an app to so it's difficult to actually talk about how much adherence to self-isolation is happening within the community. So we are not sure whether a lot of people are self-isolating or not, especially those who are being followed up remotely. Some of the things we are trying to do is to make sure if we have a higher pool of resources to do contact tracing, then some of those follow-up would be more effective. The issue of decentralization is one of our key lessons which we have taken, and we are going ahead to implement this. And of course, as much as possible, we know we cannot trace 100% of our contacts, but we want to be able to trace as many as possible, especially within settings that are a bit closed, probably in workplaces, in congregate settings, to prioritize this contact tracing to make sure that is as perfectly effective as possible in those particular groups.
Sorry, Rhoda,
So,
I need to ask you to wrap up.
Okay. So community engagement for us is one of the things that we are going to be using as our tools in contact tracing. So thank you for listening.
Thank you. Fantastic. Thanks to all of our presenters. Really amazing work and very well presented. Great information. Let's go now to Dr. Jay Varma as our discussant to put this into context.
Thanks, sorry, just unmuting myself. Thank you all very much for these really thorough and interesting presentations. Just for some background, so you all understand, I've spent most of my career working globally on emerging infectious diseases. And from 2017 through 2020, early up through March of 2020, I was based at the African Union, helping to create the new Africa CDC. So have worked with people in many of your different countries on various aspects of infectious disease preparedness. I actually returned urgently back to the United States in early April at the request of the New York City government, because I had previously worked here before and now help the mayor of the city guide our coronavirus response. Just for people's background information, you know, New York City is a city of about 8.5 million people and had one of the largest coronavirus epidemics in March and April of earlier this year. And that was the time at which I came to help after that, right around the time when the epidemic was peaking. So I have some perspective on the challenges of this managing this disease, both in Africa, in other low-income settings, as well as here in the United States. And I just wanted to highlight a couple of things that I think were most interesting. I actually think Rhoda's presentation actually echoed a lot of the things that I was going to actually say. I mean, I think Nigeria actually has a lot of similarities to the situation in the United States. And I would say first and foremost is the complexity of government. And I think what we have seen with this epidemic, first and foremost, is that the single most important determinant of success is political commitment. And that is, of course, those of us who have worked in health systems know that that is true, whether it's immunizations, HIV, maternal child health. Political commitment is the most important. And of course, when you have countries that have, or any area that has a federated system, where the central government has responsibilities, but so too do the states or provinces, and so too do the cities, you need to have political commitment, not just at the national level, but really at every level below that. And I think that the experiences that many of you are reporting, both at the subnational level as well as the national level, really echo about how critically important that is, and how the performance can be very uneven across different places when you have varying commitment. Here in New York, we have had much more success with contact tracing, probably very much in line with many of the more successful stories that people have faced. Doesn't mean we haven't had incredible challenges, and I'll highlight those too. But many other places in the United States have not had that level of commitment at the state and local level, and so have really had very inadequate performance. So I just wanted to start by really emphasizing and highlighting, you know, how important political commitment is to this success of this endeavor. I think second to that, of course, after political commitment, as we all know, the next most important step is funding. And I think here, this is where one of the biggest challenges, I think, you know, came in the United States, and maybe contrasts in some way with Africa. You know, there has been a real progressive underfunding of the public health system in the United States. And then related to that, has been sort of a progressive loss of funding for things that were not seen as absolutely critical on a day-to-day basis. And, you know, contact tracing is primarily used in the United States for sexual health, primarily for syphilis and HIV, because tuberculosis rates have dropped dramatically, and it's pretty much a low incidence and approaching elimination state for TB. So a lot of the infrastructure for contact tracing that should exist in the United States exists primarily for sexually transmitted diseases and HIV, and those have been progressively underfunded over time. Large jurisdictions that live in sort of more progressive places like New York City and parts of California have not had that problem. We've continued to fund this at some level, but many other places have not. So in this, you know, even when you have the political commitment, there's been a tremendous challenge with how do you rapidly scale up contact tracing? Now, in many places in Africa, particularly those that were hit by Ebola, there was a recognition and an ability to rapidly scale up contact tracing because of its importance to Ebola. And I think that has been a challenge that the US and Europe and other places that we thought had high capacity to respond to this, actually, in fact, when it comes to an immediate emergency, a number of difficulties in bringing people up. And it wasn't just funding, it was really just the mechanism and the experience. You know, as we know, public health emergencies are almost like muscles for physical health. If you don't use them repeatedly, you will lose them. And so even though we have capacity, it had not been exercised and used enough. And those financial mechanisms and commitment and understanding had eroded essentially over time. I would say the next thing is looking at this issue of information systems. And as we've heard, many different countries are using many different systems. Obviously, GoData is a very important platform because it is very easily scalable and usable with people with very little advanced training, and it works in low bandwidth settings. But in the United States, every time we try to use information systems, everybody wants to add on and to make sure you have a system that can apply to every situation. In other words, choosing a rapid solution that is likely to be effective quickly often loses because people raise questions about, well, how is it going to solve these 5 other problems that may occur? So I can tell you from experience here in New York City, we actually had a very flexible and high quality electronic information system to incorporate contact tracing. It's actually what we did when we had a few imported Ebola cases and have used for outbreaks of measles and other infectious diseases. But because we were concerned about scalability, we went with a commercial vendor to adapt a new system. Related to that, we were also concerned about the need to have our contact tracing system be not just for public health disease control, but also for provision of services. We felt very strongly that we wouldn't have a successful quarantine and isolation program if we weren't providing food, medications, other social supports in a centralized way. So the advantage of this is our system now can really rapidly and completely analyze data at all aspects, from testing to case investigations, contact investigations, social services, compliance with isolation and quarantine. But the trade-off was that it took us 4 or 5 weeks to build that system and incorporate it. And that is something that I don't think we will know the answer to over time, whether or not that was the appropriate investment or not. I personally think that because COVID, we're going to live with this for 6, 12 months longer, it was probably worth that delay, but that is a question that is really open to consideration. And then I would also add in here about really this issue about engagement with communities. There has been huge variability across different parts of the United States in terms of these metrics that we look at. What proportion of cases actually provide contacts? What proportion of those contacts actually follow up and answer the phone and comply with the interviews and testing and follow up? And it's been very difficult to really get good standardized metrics for this. So there's really a strong, I think, need for us as a global community, high income, low income, middle income settings, to really have a good understanding of these metrics. I myself have been a little suspicious of using this notion of the number of contacts provided as a metric, simply because there is so much variability. You know, cases that arise from their contact lists ideally should have 0 contacts, you know, because they were in quarantine. And so that becomes not so useful of a metric. And in situations where you have strong social distancing measures and people are actually staying at home, they too should not have too many contacts. Nevertheless, we need to, I think, compare data across many different settings around the world and really come to some agreement about these because they are so important. And the last point I would try to make is really to also understand the challenges of comparability when it comes to testing. We know that contact tracing begins with case investigations and recognition begins with testing. And there is tremendous variability across the entire world in the rapidity and ease with which people have access to diagnostic testing. I can even just tell you here in the United States, again, in New York City, high income place where, you know, after, you know, around my arrival here, part of my arrival here was a recognition of how much political commitment was needed. We have dramatically scaled up testing so that even in a population of 8.4 million people, we are performing about 45,000. So 45,000 PCR tests per day now, which approximates about 5 tests per 1,000 people, which is around the level of in places like South Korea at their peak. But that is not true in many parts of the United States, and we know that is not true in many parts of the world. And so we also have to think about the effectiveness of contact tracing in settings where testing is not widely available. I still think it has tremendous value because any engagement that we have as public health officials with our communities is an opportunity to learn and to teach. So even if we are not immediately reducing onward disease transmission, we are also learning about disease transmission that can inform our policies. The policies and tools that we have for this disease are very blunt. You know, individual measures like face masks and hand hygiene and avoiding gatherings are important, but community social distancing measures are also important, but they come with a tremendous cost. And so I feel very strongly that even though I make this point about testing being the entry point and there being a lot of variability, I still think it's very important for us to continue to advance the practice of contact tracing, because the more we understand our communities, the more we will understand when community social distancing measures are appropriate and when they should be relaxed, because we will really be having that human interaction that I think is so important to inform our public health measures. So I know we're short on time, so I'll just stop right there, because those were just kind of the highlights that I had. And I just want to really emphasize and thank all of you for the quality of your presentations. I greatly miss the time that I spent in Africa, and think that the successes of Africa really need to be told, because I think it's an example of where even in places that don't have the most advanced technology throughout, you know, strong commitment, strong social cohesion, and really an ability to recognize how to adapt solutions at a broad scale. These are critical lessons that Africa needs to be able to teach the rest of the world. Thank you.
Thanks, Jay, for terrific insights and helping to put things in context. I think we're just about out of time. We're gonna just ask Mike Reed from San Francisco if he wants to make a comment, and then we're gonna ask each of the countries, each of our presenters, to give us some final thoughts, just 30 seconds or so. So Mike, did you share anything?
Thanks for inviting me to say something. I mean, just for context, I help run the San Francisco Department of Public Health contact tracing program. First of all, I want to echo Jay's point. It's humbling and impressive to see the kind of response that has been stood up across countries in Africa. And I think we have huge amounts to learn from what you're doing. And again, one of the key lessons for me is the critical role of community engagement, and how you've been effective at mobilizing community health workers in many settings to do the work. And secondly, just highlighting the contact tracing in and of itself is not a silver bullet. It has to happen in concert with you know, robust public health infrastructure that in many settings in the US doesn't exist right now. A point again that Jay made. So those are the things I think I'd want to highlight, and again, just, you know, underscore my praise for partners in these countries who've done such an incredible job. Thanks, Peter.
Thanks, Mike. Now we'll just have a final round robin. So starting, we'll go alphabetically again, starting with Dr. Rhoda Atta in Nigeria. Final observations or thoughts? You're still on mute.
Thank you. What has become clear to me from this session is that a lot of the challenges, the experiences across the countries that did present are similar. So I think this gives us an opportunity to actually leverage on what other countries are doing to resolve such challenges, since our communities are really similar, and we see how we can use those in our own settings to actually improve upon contact tracing in our country. Thank you.
Thank you again for your great presentation and great work that you're doing. Now, Dr. Sabine from Rwanda, unmute, please.
Thank you. This conversation is important, and we should have it frequently. We've been learning from different experiences from different people, but what is common for us is that this virus is challenging us every day. We are learning a lot every day, and we should have learned more from the past. We'll do more for future pandemics. Hopefully not, but who knows what will be waiting us in the next years. But the partnership against COVID-19 in contact tracing, as I said, it goes beyond borders, it goes beyond countries' experiences. So we'll continue to have a conversation, and I thank the organizers to bring us together maybe for next time as well.
Thanks, Sabine. And now to South Africa, Hassan or Masuda, closing thoughts?
Thanks very much, and thanks for the opportunity to be part of this webinar, and thank you to my colleagues in other parts of Africa. It was just amazing and wonderful to hear your presentations and contributions on contact tracing. I think, Rhoda, you raised a very important point, which is around what is the value of contact tracing when you've got established community transmission. And I think that's an important policy issue that we need to dwell on, because it's a very resource intensive activity, and the role of contact tracing in that context needs clear guidance. I think for us, of course, in confined environments like old age homes or schools or factories, contact tracing is crucial and needs to continue. But when there's widespread community transmission, the value of contact tracing is limited, and we know that there are many, many more cases out there that we are not aware of. And this links to testing strategy, where the amount of testing we do is limited by the fact of how many people present for testing. If people have mild symptoms or if they are asymptomatic, we will not pick them up. And we need to be aware of the public health implications of that. But it's been a pleasure to be part of this. I've learned a lot. And I see that there are many common strategies amongst all of us, and that's really a validation for the kind of work that we are doing. So thanks very much for this opportunity.
Thanks, Hassan. Masuda, anything to add?
Nothing further to add. I think I definitely echo Hassan's sentiments, and just thank you so much for having us. It was a really great webinar today. Thanks.
Thank you. And lastly, to Uganda, Alex.
Yes, thank you very much, everyone. I just must say that Uganda is actually a model country in terms of response to epidemics. We are very experienced. We've done very well. But I can assure you that COVID-19 has challenged us. And we have realized that we still have a lot to learn. And going by the experiences that we've shared today, I think we have a lot to learn from each other. I want to thank you, Peter, and the team for really organizing this kind of seminar. There are a lot of similarities, of course, in Africa, and I think we still need to learn from each other. We've also seen the value of relying on non-traditional health systems, of going down and then seeing how best we can do things. You all agree that tracing contacts have overwhelmed our systems. So I think this is a fundamental lesson that we've all learned. And with outbreaks yet to come and bigger ones, we need each other. So we need to learn more from each other. So thank you so much for organizing this, and we shall participate more in the future discussions. Thank you very much, everyone.
Thank you. Jean, my co-host from AFREhealth.
Thank you. I just, on behalf of AFREhealth Governing Council, I just wanted to say first thank to Peter and Fogarty for putting this, but also to all the speakers. We would like to keep in touch with all of you in terms of partnering with AFREhealth in education, research, and policy. So we will keep in touch and getting back to you in the next coming weeks as we try to leverage this COVID response with many partners with support of Fogarty. Thank you very much. This was really eye-opener, and I learned quite a lot. Thank you.
Thank you, Jean. And just again, I want to thank all of our presenters. Really fantastic work that's going on in Africa. And we know you all have really leadership positions in the response. So to take the time to put together your presentations and share your knowledge, we very much appreciate it. It's been very helpful. I hope it's been helpful for you to each other, but certainly helpful to us from the US perspective to see the successes that you have. There's to me, one of the striking common themes is decentralizing, and how do you ensure the quality and get the information and the coverage with these really high numbers of cases and having to decentralize. So thank you to what you've shared with us. Thanks to Jean and AFREhealth for co-hosting. We will make the recording available on the AFREhealth website, so keep an eye open for that. And thank you again to everybody, and over and out.
Thank you.
Thanks
Bye.
so much. Thank you.